Let me see. You can see me now?
Yes, sir.
Right.
Good
Good
evening.
evening.
Good evening, sir.
So shall we continue with the second session of ECG? We done one session last week.
Yes,
Were
sir.
all the present participants currently on the screen? Were you there for the last session?
Yes, sir.
Yes, sir.
Yeah, because just for continuity, it'd be easy to know so that I can pitch up at level, so that I can move. And please stop me if you're not able to follow any particular thing. We can discuss then and there, or you want to discuss at the end. So we discussed the basic ECG a few days ago. Today we are going to discuss about how to interpret. Okay. So last week was about how to read the basic ECG in the sense like how to calculate the heart rate or how to look at the ECG, in short. Now, like today, we are going to apply that. It's more of application today's class. So I'm going to focus, since it's an ECG tutorial, I'm going to focus mainly on the ECG interpretation. I'm not going to go in detail with each management, For example, if it's an acute MI, I'm not going to go into the detail about management protocols, because that itself is a different, or altogether is a separate class we can have. Are you clear with that? Hello?
Yes.
Yeah. Can you just confirm whether my voice is audible or you want me to increase my volume?
Perfect, sir. We can continue.
Okay, that's fine. Shall we move on? Yeah.
Yes.
So just to recap from last week's one, this is what the normal ECG looks like. If you remember, like each P wave will be followed by a QRS and T wave at the end. Okay. So without wasting much time, so we can go on to the further slides. Do you have any class after this one for today? Fida?
No class.
Fida, can you hear me?
No other classes.
Okay, that's fine. Okay. And I just want to see like how much time we can spend, in case if you have more doubts, we can go slow rather than rushing up. Okay.
Okay.
Okay. This is also the same slide we've seen last week. Just to recap about the P wave, followed by the QRS complex, and this J point, and then you have the T wave, and followed by the U wave in some, some cases, not all. Let me just minimize this one. Sorry, I'm just trying to sort out my screen here. Okay, so the main aspects why we do an ECG is somebody comes with a chest pain. So you're the admission day doctor sitting in the casualty. The first thing you ask for is an ECG. So when you ask for an ECG, we should be knowing what is the thing we have to look for in ECG to diagnose. Before, when you order any test, we should have an idea why we do this test. Right? So ECG, as we discussed, it can bring out a lot of the diagnosis, which is easy by just doing a surface tracing. So one of the things is like, the main thing why we do ECG is just to diagnose acute myocardial infarction or a heart attack. ECG is a main cardinal test which is used. You can do it anywhere, like in the OP setting or in the ward setting, or wherever you have that small machine. Okay. Subsequently, like there are other tests to confirm, like the troponin I and all, which we'll discuss later. Okay. So the idea of doing ECG is just to see whether it's normal or abnormal, especially in the background of somebody coming with a chest pain. So the main thing what we're looking at when somebody is, the first thing we're going to discuss is about the myocardial infarction. Subsequently, we are going to discuss about the heart blocks, how to diagnose or know on the ECG heart blocks, on the conduction blocks, bundle branch blocks, which we'll discuss in the subsequent ECGs. So we'll just go one by one. Please stop me if you cannot follow any particular thing or if you have any doubts, we can discuss those points in detail. As we discussed earlier, this is the J point and this is the ST segment. It should be isoelectric, which means if you draw a line from here, this should just go through this one and it should match along this line. Anything above or below is pathological. It's not physiological. Sometimes rarely you can get a slight ST depression if the heart rate is very high, it's tachycardia. So the next few ECGs next few slides, we're going to focus on the main area here. This is the J point. After this, what happens after the QRS complex, mainly in the setting of the acute MA. If you look at this ECG trace, are you able to see this slide? Is it clear? Hello guys, can you hear me?
Yes, sir.
Yeah, okay. If you look at this, this is the QRS complex in the ECG trace, and there are 3 or 4 different types of elevations. Ideally, this level should be here. Okay, but here in this ECG, it's elevated. It's called ST elevation, which is pathognomic of an ST ST segment elevated MI. STEMI is called STEMI. There are 2, like, if you know the current classification is acute coronary syndrome. It ranges from STEMI, which is ST elevation MI, to non-STEMI, where you don't see an ST elevation, but it's also a type of heart attack. So in between you have unstable angina and other few other categories. But there's ACS is a broad category. So I'm sure the theory would have been read in the textbooks, but it's a very broad category. If you label somebody as an acute coronary syndrome, the more meaningful term is whether it's an ST elevation MA or non-ST elevation MA. The treatment is different. So in this trace, if you look at this is the QRS complex. Ideally, it should have, this line should have come over until here, but it stopped here, and there's ST elevation. Okay. Here also it's a flat ST elevation. Here just a bit more code ST elevation. These are just reflective of different patterns of ST elevation. ST elevation, you don't get it like textbook pattern in all patients. It can be variable and it can mimic like this. And we have to interpret the ST elevation in the context of chest pain or the patient's presentation. If you look at this ECG trace, each P wave is followed by a QRS complex, though the QRS complex looks slightly wider. If you remember, the QRS duration should be around 0.10 second or millisecond, rather 100 milliseconds, a maximum of 110 milliseconds. In this one, this is the chest leads V1, V2, V3, V4, V5, V6. If you look at this one, this is a P wave, biphasic P wave, and this is a QRS complex. It should stop like this, but it just gone up. This is ST elevation here. Okay, if you look at this one, it just there in the, excuse me, it just progresses in the V1, V2, and slightly settles down in V3. Okay, and also if you look at these leads, like V4 to V6, is a T wave. They are inverted. They should be upright like this. They should be like this, pointing upwards. Yes, most of the leads is inverted. So it should be like upward direction. Here it's like downward direction. Okay. You could see it's all downward direction. It should be like a P wave, like going upwards, like this one. Okay. So the idea of doing the ECG is we can locate whether the patient is having a heart attack, whether it's a type is whether it's an ST elevation MA or is a non-ST elevation MA. Okay, then we can also interpret based on the appearance or the lead presentation. We can say which wall of the left ventricle is having the heart attack or myocardial infarction, like whether it's an anterior wall myocardial infarction or lateral wall or inferior wall or posterior wall. We can look at the ECG and we can tell. If you remember, this I showed a different Can you see this slide with the anatomic groups?
Yes. Yes, sir.
Yeah, this is the ECG. This is a slide from the last week. Like this is just representation of the 12 lead on the ECG trace. Lead one, lead two, lead three, and you will have this AV or AVL and thing. For the anterior, like wall MI, like we should have like from V1 to V4. V1, V2 is usually anteroseptal, okay, and the anterior wall can sometimes extends to anterior wall can go up to V5, V6. So this is anterior wall MI, which is reflected in this. Let me just go back to this one. Yeah, which is shown in this. So you need to just remember this slide. The idea of putting this slide again is just remember this is a 12 ECG where you have a lead one, lead two, lead three. No, all the other lesser leads are there. Based on which leads have the ST elevation or ST depression, we are going to call that lead all the wall, like anterior wall, inferior wall MI, or posterior wall MI, based on this presentation only. So if you remember, like just have it in your mind, like so it'll be easier for you to interpret. Okay, coming back to this ECG rings. So, do you all think this patient is having an acute MI or is just a novel variant? Uh, Sorry to interrupt. Like, I would like you guys to be more interactive. Just feel free. Like, don't think this is more like a lecture or some like things. I would like because ECG, unless you guys like interact, it will be difficult to understand. Once you get the basics right, then it'll be easy for you, like you will able to build up your knowledge based on that one. So I would like you guys to keep your mics on, like if you want, like you can answer, like saying like, because next few slides we are going to have this kind of interaction, and at the end there's a quiz, easy quiz. So I would like you guys to be participating. I know like you are a final year MBBS student, so
Okay.
don't worry, like that you're going to answer it wrongly. Like, we all learn, like as I told you last week, I'm still learning, like 23 years down the line since my house agency, still learning. So it's like a learning curve. So there's nothing, no harm in like making a wrong attempt, like it's always learn. The worst thing is like making an assumption that we all know everything and they're not coming out. That's the worst thing. Rather, we can make the mistakes here and we can rectify. Once you finish your training, then you'll be better at it. Okay, so I like you guys to be like interactive. Like, do you all think this is a normal ECG? Yes or no?
No, sir.
No. Good. Okay, why do you say no? We just discussed. Anyone? Any takers?
ST elevation.
SC elevation. Good. Which leads? We discussed everything just now.
V1, V2.
Excellent. Anything else?
T-wave injection.
Yeah, T-wave inversion is the multiple leads. Okay, so it's not a normal ECG. Okay, so we are suspecting a myocardial infarction in this patient. This is called acute anterior wall infarction because the anterior leads are involved. Am I clear?
Yes, sir.
Because we label, because acute MI, we label based on the ECG, like leads as anterior, posterior, or inferior lateral wall based on the ECG with the slide which I shown you just now, the colored slide. So if you remember that one, like when you interrupt an ECG, like you can tell, like core is asking you whether in the exam or maybe when you become a house surgeon. So your PG may be asking you, what do you think with this ECG? Then you can tell it's in acute anterior wall or like whatever the wall based on the presentation. Okay, well spotted. Good. Okay, this ECG normal or abnormal?
Abnormal, sir.
Good, abnormal. So may I know the name? Who's the person answering? Sorry, I can't see this because I just minimized the screen because I just put on a slide.
Niraimuri, sir.
Niraimuli, good. So why do you think it's abnormal, Niraimuli? Anything you found on this ECG? Just feel free, Okay, let me just next few slides I will guide you guys, and then towards the end of this session, like I'm sure you'll be able to interpret or you'll be able to pick up the abnormal findings. The ECG is more, it's like a mathematics. The more you practice, it's like a maths, like you can have only one answer. You can have different patterns of now doing the sum, like detecting the thing, but the answer is only one. It's ECG similar to that. If you know the technique, it's easy. The technique is like first you should, whenever you get an ECG, first you should check the name, whether is this patient, this ECG belongs to this patient. Because sometimes in the busy casualty, you'll have a different patients with chest pain. There'll be a lot of ECGs flying around. Check the ECG name, date, whether it's dated like for today's date or whenever it's taken, okay, and the patient's age. These are the three things you should look for. Whether it's an X-ray or ECG film, you should look for these things. Check the patient's identity. Then you go for whether it's a sinus rhythm or whether heart rate is normal or whether it's ST elevation or Z or normal ECG. Then you can interpret those. Good, like you said it's abnormal. Yes, it is abnormal because we could see there's a deep T wave inversion in lead 3 AVF and also lead 2 and 3 AVF and also deep Q waves. It's like an evolved inferior wall myocardial infarction. If you remember, the reason I'm saying this slide is this is going to be a very vital slide. If you want to master the ECG, you should know which lead you're talking about. If you look at this lead 2, this 2 is lead 2, lead 3 AVF is inferior wall of the left ventricle. The reason I keep on stressing these things is like the basic is the main thing. ECG is, most people they think it's difficult. Actually, it's easy because you need to spend more time when you're learning at this basic level. Some people like they'll try to jump into conclusion like straight away they want to get the diagnosis. That's not the way you read ECG. ECG is just it's a schematic or structural way of interpreting. Then if you do that way, you won't miss any subtle things or you won't miss the major findings. Okay, so it's an evolved inferior wall. There's some slight ST high uptake is there as well, but this deep is almost evolved because the heart attack is almost nearly completing. It's normal ECG or abnormal ECG? Come on, guys, you guys are all intelligent.
ST elevation.
Good, excellent. Which leads?
V2, V3.
V2, V3. Excellent.
V4,
Good.
V4.
Okay, good. One important thing.
AVL.
Yeah, good. AVL, yeah. One interesting thing about ECG in patients having acute MI is when you have an ST segment elevation MI, yes, that's STEMI. For example, if you have in the anterior wall, then you have what is called reciprocal changes. You might have heard about it. What it means is like opposite to the leads of the anterior wall, you will have ST depression. If you look at carefully, if you look at the inferior wall here, there's some slight ST depression. Can you see how this is the isoelectric line, but you could see there's a depression there. Okay.
Yes, sir.
Similarly, like if you draw a line, this is isoelectric line. This segment, ST segment, is below this line. So even here in the AVF, it's slightly down. But here in this anterior leads, it's elevated. So that's very pathognomic of an acute MI. Sometimes you can get an ST elevation, not due to heart attack. There's various reasons you could get an ST elevation. The main thing which is important is when you look at any ST elevation in any one particular wall, look at the opposite wall, like opposite leads. For example, if you get in an anterior wall, look at the inferior leads to see the reciprocal changes are there. That means if there's ST elevation here, it should be ST depression in these leads. So that's a very definite sign this patient is having a heart attack or myocardial infarction. Okay. So it's good that you picked up all these changes. ST is an anterior extensive anterior wall MI. Yeah, it's extensive. See, it also involves a lateral wall because it's an exterior anterior wall. It almost covers the whole of the anterior part of the left ventricle. Yeah, well spotted. So this is ST elevation MA. I'm just going to show one slide just for ST depression. Yeah, just to summarize briefly, the acute coronary syndrome is a broad category. Like as I mentioned earlier, it can be like from unstable angina to non-ST elevation MA to ST elevation MA. The main difference between STEMI and non-STEMI is in the STEMI, that's ST elevation ME, there's complete blockage of the artery, the coronary artery, whichever artery is involved, whether it's right coronary or left coronary, or the subsequent branches like LAD or LCX, circumflex, whatever the vessel is involved, is a complete blockage due to ruptured clot or the thrombus. In the NSTEMI, it's like incomplete blockage. That means it's more dangerous because you can get subsequent dislodgement and distal embolization can occur, and that can be more complicated. And this is much more, NSTEMI is much more difficult to manage than the STEMI. This is just a pathology, like it's given nicely in all the medical textbooks, like Robbins or things. Yeah. So let me go back to this. I'm not going into the detail of the treatment now. Let's have it on a psychological. I'm just trying to show the ECG with the ST depression.
Sir, screen is not visible.
Oh, it's not visible, is it? Sorry.
Yes.
Let me see if I can, because I just came out of the slide presentation into a different one. Don't worry, that's fine. Let me just go back to the original slides.
Okay, sir.
So are you still seeing my previous slides, or are you seeing the screen now?
No, sir.
No, sir.
No, it's not. Sorry, let me just go back. Can you see it now?
Yes, sir.
Okay, sorry. Now just trying to show a different the presentation about the ST, no, non-ST elevation MA, but don't worry. Like, let's carry on with this one. Looks like some problem in the sharing. Before we move on, like in the this is ST elevation MA. If there is an NSTEM, just non-ST elevation MA, instead of these ST elevation, you will have these kind of changes here. There'll be ST depression. That's called NSTEMI. Non-ST segment elevation. That's much more dangerous than a STEMI. STEMI, at least it's the whole vessel is blocked, so you can thrombolize or you can do a primary angioplasty, so you can remove the blood clot and remove it. But in this ST, the non-ST segment elevation MA, where like you will have a incomplete blockage of the coronary arteries, that's much more dangerous, and that's why it needs to be monitored very closely. Next, I'd like to just briefly touch on the bradyarrhythmias and tachyarrhythmias. Brady is obviously, like it's slow, tachy is fast. So let me just go back to that slide where we had this conduction system. Let me just, yeah, it's there. Okay. Can you see this slide?
Yes.
Yes.
Yeah. Okay. This is the SA node, and if you remember this slide, we had the teaching last week. Your cardiac conduction starts from synovial node, and it's just go to the SA node to the AV node, and then it just divides into right and left bundle branch block. Sorry, right and left bundle, and then it's goes into the ventricles, and it is the one which causes the contraction of the atrial chambers and the ventricular chambers. The impulse is conducted from above downwards. P wave corresponds to atrial contraction, QRS corresponds to ventricular contraction, and T wave corresponds to ventricular relaxation or repolarization. Contraction is always called depolarization. Okay, if you remember this one, like this part is the atrium, right atrium, left atrium, RV, right ventricle, left ventricle, and this is the junction, atrioventricular junction. So where you could see this dividing into two like chambers, and then the branches, the conducting system. It's important you just have an memory in your mind about this tract from going from above downwards from atria to ventricles. The reason is I'm just going to show you some more slides. Bradyarrhythmias and tachyarrhythmias, the problem can be occur in the cardiac pacemaker, that's the SA node, or it can be further down, like whether in the AV node or in the bundle branches. So how do we know the problem is whether it's SA node? How to diagnose ECG? I will tell you in a few minutes. Okay. So it's broadly if there is any problem from the sinus node, let's see sinoatrial node, it can be firing at faster pace or smaller pace, sorry, a slower pace. If it's fast, it's tachycardia. If it's slow, it's bradycardia. Because normally there's what we call as a functional, when you try to do some exertion, jogging, or if you're running, your heart tends to go slightly tachy. That's a compensating mechanism because your body needs more cardiac output. The stroke volume has to be increased. So that's why the heart rate increases to keep up with the oxygen demand for the myocardium and rest of the body. So the bradyarrhythmias, that's a slow, the arrhythmias are classified into sinus. It can be from the sinus node, a junctional at the level of between the atria and ventricle, and sinoatrial node, SA block. It's been between the sinus node and the AV node, and the atrioventricular block is between these atrial chambers and the ventricles. Because if you remember, it's like electrical activity passes from above downwards from the atrium, right atrium, and just goes into the the AV node and down into the ventricles. If you guys see this ECG, if you remember, I just given a brief. I just given a brief explanation last week about how to read what's the heart rate on the ECG trace. If you look at this ECG carefully, it's the number of big boxes is 1, 2, 3, 4, 5, 6, roughly 6. So the calculation is for the big. If you're counting the bigger boxes, it's 300 by number of big boxes in between these two RR intervals. So in this, roughly, it's about 6 big boxes are there. That means 300 by 6 is 50. It's roughly about 50. But if it's not falling on the points, if it's falling in between on the smaller, the smaller boxes, then you have to use a different calculation. It's 1500 by number of small squares. Each big square contains 5 small squares. Sinus bradycardia, the heart rate is usually less than 60. Tachycardia is more than 100. Okay, here you can see it's regular because each P wave is followed by QRS complex and the T wave. So it's regular. So it's slightly slow. That's why it's called sinus bradycardia. Junctional rhythm. So the junctional rhythm is between the atrial and the ventricular chambers. If there's any problem with the conduction around that area, then you will have this kind of pattern on the ECG where your heart rate is roughly around 40 to 60 beats per minute. Okay. And it's regular. If you look at this one, this is very irregular. I'll show you this behind it. I'm sure you see. Just if you move this thing, if you take a white paper and if you draw these two lines and if you try to move it across, that will be equal or symmetrical. Let me just draw and show you. Sorry, it may be difficult to show it on this one, but just to see this one, this step on this step, if you just like with an ECG trace, if you draw a line with a white paper and if you move it forwards, this will correspondingly follow the same level. There won't be any falling before or falling afterwards. In this one, anybody can pick up anything in this ECG apart from the one I mentioned? Hello, you guys are listening? Hello.
Yes, sir.
Can you see the P wave?
Yes, sir. Yes, sir.
Can you see the P wave?
No, sir.
No, sir.
Missing. Just make a note of this one. The P wave is missing, but the QRS complex is regular. So that's why it's called junctional rhythm. If the P wave is missing and if this QRS complex is irregular, that means that just this gap doesn't tally with this gap or doesn't tally with this one, then it's become like an atrial fibrillation. That's irregular, chaotic. Okay. This is something called SA block. It's called the exit block or like sinoatrial block, where like there's a normal complex. There's a P wave, QRS complex, T wave, and this is a normal complex. And suddenly the sinus node fails to initiate the next beat. That comes as a pause or a block. Instead of having, there should be another complex like a P wave should be here, QRS should be here, T wave should be here. This is missing. But if you take these two like RR intervals, this will be exactly, if you draw another one, this will come exactly in the middle. And the next P wave is coming in the normal, and subsequently this is becoming normal. So this is called sinoatrial block or exit block, because sinus node fails to beat at this point. You could even feel in the pulse, like the pulse will be regular. After like few beats, there'll be missed beats kind of thing. The common causes, like usually it can happen in young athletes: digitalis toxicity, hypokalemia, sick sinus syndrome. Where it means like your sinus node is not functioning well. That's sick sinus syndrome. Patient might have a bradycardia or disease first. Next, we move on to the AV node block, which is atrioventricular block. There are three categories in this one: first degree AV block, second degree, and third degree. Let's just see on ECGs. First degree, like main thing is like the PR interval. If you guys remember, like PR interval is from the start of P wave until the R wave. Okay, the normal PR interval duration is between 3 to 5 small squares, or 120 milliseconds to 200 milliseconds. Anything less than or anything more than that is abnormal. If you look at this ECG, if you draw if you mark from here until here, it just comes around PR interval is about 280 milliseconds. Normal PR interval should be less than 200 milliseconds. So this is elevated PR interval, and that's how things are normal in this one. There's always a P wave followed by QRS complex, the T wave, P wave. Everything is regular. There's no other abnormality except the PR interval. That's why it's called first degree heart block. It's usually common after an acute ischemic event like a myocardial infarction or any myocarditis like rheumatic carditis. You can get after a severe vagal tone, increased vagal tone, beta blocker. So these are the common causes like digoxin. Second degree AV block. First degree AV block is PR interval is 1. Second degree AV block, like how we diagnose is like there's intermittent failure of AV conduction. The impulses coming from above from the sinusoidal node is sometimes blocked at the level of AV node. Under the secondary AV block, you have two different categories, which is like morbid type 1 and morbid type 2. Type 1 is called Wenckebach's phenomena. Just let me show an ECG. Right here, if you see this ECG, can you see this P wave? Are you able to see the arrow pointing? Yeah.
Yes, sir.
Yes, sir.
If you see this one, this is normal P wave or the QRS complex, T wave, and another P wave. If you look carefully between these, the interval or gap between these two things, like from here until here, if you look this slightly widen here, if you follow this subsequently more widening here, and this the long gap, what it means is like the PR the interval, like RR interval. This is called RR interval. This is RY. This drag is until skip the beat, and then it becomes normal again, and it just keeps continuing the same thing. After one of the beats is just missing again, then it becomes normalizes. So it just kind of like intermittent conduction block. So it's called the Wenckebach's phenomenon. Here you can see like the P wave, chaos complex T wave, and then there's, if you look at this gap, is slightly widening, and then like suddenly there's a big gap there. That's where the 3:2 block. Like for every two, this is only 2:1 block. And for every 3 beats, there's one is missing. So this morbid stride tool, like where you'll see it's basically a sign of the bundle bench disease, or like bundle bench block problem. So it's much more severe than the morbid stride one. Here, like you'll see the P wave chaos complex is normal. Suddenly the whole complex will be missing, and then subsequently after this beat, you'll have a normal chaos, and this length will be equal. If you look at this RR interval, this will be same. But in Wenckebach's or the type 1 morbid's, this gap was widening for a while, and then suddenly there's a long pause. That doesn't happen in type 2 morbid's. Don't worry, it is all a bit more confusing, but the more you look at the ECG, the more you practice, like mathematics, you'll get it. I just wanted to briefly go through these things so you'll be able to know what are these types. Like when somebody asks you what is morbid's, and you'll be able to answer. The 3rd degree heart block is much more complex, or it's very serious if you put it that way, because it can cause complete heart block. Means like you can go into cardiac arrest. The risk is always there. The main problem is the atria, and if you look at the atria contracts and then the ventricle contracts. But here in the complete AV block, because the electrical impulse doesn't follow the synchronous pathway from above downwards, atria contracts on its own, ventricle contracts on its own as a pace. So the blood doesn't go anywhere. It just kind of oscillates between these two chambers, or sometimes very little blood is coming out of the aorta. People will have giddiness, dizziness. There's always a chance for cardiac arrest because of this complete heart block. The usual treatment, or the treatment to prevent any further complications, is having a cardiac pacemaker. Here you could see like in this ECG, if you see the atria, like P wave will have its own rate and the ventricle will have its own rate. This is one P wave, this one P wave, this another complex missing here. If you calculate the P wave, like the P wave rate is around 100, 1, 2, 3 big boxes. But if you calculate the rate of the ventricle, QRS complex is the ventricle thing, 1, 2, 3, 4, 5, 6, 7, 8, almost around 40. 300 by 8 is like it just comes roughly around like the 4, like the 40 the beats per minute. So they're having a very disorderly contraction. It's another ECG example of third degree heart block. It's the same AV dissociation. Okay, next we move on to what we call supraventricular tachyarrhythmias. Supraventricular arrhythmias are anything happen above the level of ventricle. That's supraventricular. Usually it's the level of the atrium. So the common thing which we come across is atrial fibrillation. I'm sure you must have heard about atrial fibrillation, especially when you present the rheumatic heart disease. Like you always check for the atrial fibrillation, rheumatic, mitral valve disease. You always go for checking whether the patient is in a sinus rhythm or atrial fibrillation. And the next category is atrial flutter, and PSVT, it's paroxysmal supraventricular tachycardia. I will show the ECG and explain to you in detail. Atrial fibrillation, if you look at this ECG trace, okay, there's chaotic, like it's difficult to see, is there a definite P wave here? All these are like, the disturbances. It's not the P wave. You might think this is a P wave, this may be a P wave. Actually, they are not P wave. They are like disturbances because of the heart rate is like fibrillating. You'll have this kind of undulations. This is the QRS, is the ventricular conduction. You could see there's a varying RR interval. This is R wave. If you draw a line in between, this gap is bigger than this gap, and this gap like bigger, and this is bigger. and they suddenly become smaller. So it's called irregularly irregular, the rhythm. So it's chaotic. Okay, so when you feel the pulse, it will be irregularly irregular, and it's quite common problem which we see quite often in our practice, and especially in the setting of the mitral valve disease, the rheumatic heart disease. But we are not seeing a lot of cases these days because of the advances in treatment, and the rheumatic fever is managed, and the cases are decreased very very much when compared to when we are doing MBBS a few years ago. So the main thing is like you have to, when you look at an ECG, look at whether the RR interval is regular or irregular, and look at is any RR interval is followed by the PR interval is QRS complex is followed by the P wave and the T wave. So if you have see the ECG, a lot of undulations, it's difficult to say which one is P wave, which one is T wave. So obviously it's an atrial fibrillation. That's why you can't identify the P wave there. So next thing is like if you get a patient with atrial fibrillation, then you need to know what is the heart rate, because there's something called fast AF and slow AF. So to know that, like you have to use the calculation which I mentioned earlier. Just calculate the number of the complexes between the two RR intervals, and you can work out. But this is going to be difficult. If you calculate between this gap, the rate will be different to if you calculate this one. So what people tend to do is they tend to calculate the average distance for the 10 complexes, like 1, 2, 3, 4 kind of thing. And they draw on a paper, white paper, and they mark it, and they calculate the average. So it's roughly about 100 beats per minute. So obviously it's irregularly irregular. P waves, you can't see the P waves. PR interval, difficult because there's no P wave. You can't say QRS duration. It's almost like in the normal range. It's not slightly smaller, but it's not like So it's the case of atrial fibrillation. So anyone like to tell like whether it's normal ECG or abnormal? Normal? Hello?
No, sir.
Okay, abnormal. That's good. What is abnormality?
RR interval.
RR interval differs, sir.
So just look at this trace. The beginning, like you could see, almost it looks like almost equidistance until here. After this, like you could see, it's just slowly becoming like smaller, becoming smaller. Then it's becoming bigger. So it's very irregular. RR interval varying. It's called varying RR interval. It's difficult to calculate the heart rate. Just you can give a rough estimate, like it just varies. Like if you calculate the heart rate here, it's different. If you calculate the heart rate between this interval, it's different. So yeah, that's a difficulty. Obviously, we discuss is a regularly irregular P wave. Yeah, you could see P wave here, but it's difficult to see whether the P wave here. Can you all see this is a P wave? There are some normal
Yes, sir.
there are some normal complexes. There are some complexes where you don't have a P wave. So that's why it's called regularly irregular. If you don't see a P wave at all anywhere, then it's become irregularly irregular. That's atrial fibrillation. It's called paroxysmal supraventricular tachycardia. Don't worry about the name. Like you will get familiarized once you start like seeing more ECG or maybe in medicine, house agency. Okay, anyone like to comment this ECG? So far we're discussing about a lot of things. There's something strikingly like telling your eyes on this ECG. Anyone? Come on, guys. Like I just want to make it interactive. Like feel free. Like I don't want to be like more like a lecture. ECG, like it's just not. If you see this lecture, it's difficult.
It is flutter, sir.
It is excellent. Why do you say it's a flutter?
Sawtooth appearance of the ECG.
Fantastic. Is it Anushibia? Is it?
Yes, sir.
Okay, that's good. Yeah, if you look at this ECG, like you could see P wave, QRS complex, no, T wave, like you could see this sawtooth appearance. But the important thing is, like, if you look at this RR interval, this R wave and R wave, RR interval between these two waves, it's regular. Atrial flutter, you will have a regular RR interval. So you could feel the pulse, it's very fast. But the main striking feature is it's like a sawtooth. Yeah, this is a flutter wave, more like a pointed. Okay, so we discussed, so far we discussed about the arrhythmias occurring from the atrium or atrial chamber. That's above the, the level of ventricles. Now we are coming to the, briefly going through the ventricular arrhythmias. The two important things are ventricular tachycardia and ventricular fibrillation. Let's look at the ECG and discuss in detail. Anyone like to comment on this ECG trace? Normal, abnormal?
Abnormal.
No, very good. What's abnormal there?
RR interval reduced.
Salty.
Sorry? Yeah, if you look at this ECG, it's difficult to say where is the P wave. You could only see the QRS complex, and it's very broad. To look at it, it's difficult to say like how much is the distance. It's very broad complex, and it's regular. You could see if you draw a, like, if you measure this distance, it will be same as this. If you draw a line along this one, they will be equal between these 2 points. That's called a regular broad complex tachycardia. If you have an, if there's any question in your exam, like, do you guys have MCQ still in the exams, or only just a theory?
No
Theory, sir.
Sorry,
Theory, sir.
the theory. Do you get MCQs? No, it's only question and answers. Is it? Small short.
Yes, sir. No MCQs.
No, we used to have 30 MCQs when we do when you're doing MBBS. So this we get these kind of tricky things. So excuse me, someone son is knocking the door. Just let me open the door and settle in. So if you get a regular broad complex tachycardia, that's ventricular tachycardia. So it's until proved otherwise. Look at the heart rate, just about 160 beats per minute. It's regular here. That's ventricular tachycardia, VT in short. It's another trace. Anyone like to comment on this ECG trace, rhythm strip? Normal, abnormal. If it's abnormal, what is the abnormality there? You all gone very quiet. You're tired or bored.
No, sir.
So if you look at this ECG, it's definitely subnormal, isn't it? Okay.
Yes.
This is the QRS complex. It's very broad. Okay. And if you compare with the previous the rhythm strip, you could see here it's irregular. Even the QRS complex, some are short, some are tall, and they're also more wide. Some are like the short. So it's very varying. So if you get a taste like this, it's called ventricular fibrillation. It's irregular. Their ventricular tachycardia is regular. Regular broad complex tachycardia is VT. VF, like, you don't see any regularity. It's called VF. This is medical emergency. You'll have to defibrillate the patient to save the patient. So you need to have the cardiac arrest, the resuscitation team with you, and you should have the defibrillator to hand. If you delay, the patient is more likely to die. Like the longer the duration between the VF and the shocking, then the chances slowly goes down. With each passing minute, you will lose between like 8 to 10% chances for successful recovery of the circulation. That's why it's very important. If you see this, then you know there's a big trouble waiting for you. So especially when you're in the middle of the night in a casualty, like so you won't be able to feel a pulse in this one unless you DC shock the patient and revert to sinus. This is a summary of the conduction from SA node to AV node and subsequently into the ventricles. And in the ventricles, we have something called Purkinje fibers. They are very specialized conducting fibers. Yeah, this is another ECG of paroxysmal supraventricular tachycardia. This is just a repeat of the previous ECG we discussed. Anyone like to give a diagnosis?
Ventricular
Ventricular
tachycardia, sir.
tachycardia.
Yes. Done. It's almost a repeat. Anyone want to give a guess?
Ventricular fibrillation.
Fantastic. Okay, just a couple of slides about left ventricular hypertrophy. You must have heard like from our pathology, Robbins time itself, like about they would have kept the specimens about slice of the myocardium or the heart, showing the thickness. It's called hypertrophy. The common cause why you get a hypertrophy is hypertension, systemic hypertension. But there are various reasons like hypertrophic cardiomyopathy syndromes, there's HOC and HOCM, so various things. So let's not go into detail. Let's focus on the current ECG. If you look at this left ECG, left trace is a normal looking ECG. Because if you remember, like I told you the other day, from the V1 to V6, that the chest leads, your QRS should gradually grow taller. Like it should start smaller, like a child, like they grow gradually. With each passing year, they get taller until a stage. Like that you should get. This is a normal ECG. But if you look at this ECG, it's more negative. That's because it's anything below the isolated line is negative, more negative deflection, and it gets only worse. It's just more negative. That's abnormal. The reason is the heart muscle is very thick, and if you remember, we discussed about axis, QRS axis last week. It has something to do with this pattern in the ECG. Because of the muscle thickness, you're having a varied or like the morphology of the ECG is different from the normal ECG. You could see the QRS complexes are very tall, and it's a voltage complex is very tall here in the left ventricular hypertrophy. Usually it's called as LVH. How to quickly calculate or quickly say whether this patient has LVH on the ECG? Like you could just go. There's a calculation or the formula. R wave in V5 V6. Okay, R wave. So we discussed the Q wave is the first, the negative point after this is a Q wave. R wave is the subsequent, the tall one, and the S wave is anything goes below the isoelectric line. So this is the R wave, and if you calculate the R wave in V5 or V6 leads and add it with the S wave, this is the S wave. S wave in V1 or V2, it should be more than 35 millimeters, because in ECG trace you will have the millimeters and the duration along the X and Y axis, which we discussed a few days ago. So if you remember this, then you can use this calculation, and this should be more than 35 millimeters. Put it together: S wave in V1 or V2, R wave in V5 or V6. Yeah, it is another thing. Sometimes because of the severe left ventricular hypertrophy, you could have like on the ECG, there's some slight ST depression. That's called a ventricular strain, left ventricular strain pattern, because muscles are very thick and the heart is struggling to pump against the thick muscles to supply blood to the coronary and the myocardium. Yeah, that's the one we discussed. Okay, just a few slides about the bundle branch blocks. We discussed about the heart blocks. That's different from the bundle branch blocks. Heart blocks are 3 types: type 1, type 2, and type 3. Type 2, we have 2 types: Morbid's type 1 and that's Ventricular and Morbid's type 2. And the bundle branch blocks is the 2 types: right bundle branch block and left bundle branch block. If you look at this slide, that's your SA node, and this AV node comes your atrioventricular junction. And from here, you could see the 2 branches, right and left. That's called right bundle and left bundle. They go and supply the respective ventricles. Left bundle supplies the left ventricle, right bundle supplies the right ventricle. If there is any problem with the conduction here along this one, it causes the left bundle branch block. And any problem with the conduction down here causes the problem with the conduction to the right ventricle. Subsequently, the pumping may not be adequate. We could even pick up those things on the ECG. Okay, let me just go to further slide. Yeah. Let's go to RBB first and we'll come to LBB. Yeah. If you look at this ECG thing, if you see an ECG, like if you have a very deep complexes, this is a Q wave, QRS complex, then you know it's a LBB pattern. Let me just go back to ECG. This is RBB. That's, yeah. If you look at this ECG, like it's a deep Q wave in the anterior leads or V1, V2, V3. If you look at this ECG trace, you could clearly see there's like widening of the QRS complex and there's a deep Q wave in the anterior leads. Sometimes you could see like a W pattern, and if you see the kind of W pattern in V1 with the QRS complex, it's not like fully clear here, but there's something called William and Morris pattern. William is like W. You could see the W shape pattern like complete or incomplete, or the LBB, left branch block, and V1, V2. And as you go along the same ECG in V5, V6, you will see more like a M pattern. It's not very clear here, but I'll show you another ECG. So V5, V6, you will see M pattern. Here you could see there's a slight, it's not a smooth slope. So that's the left bundle branch block. This is a ECG showing right bundle branch block, where you will see in V1, V2 leads, or maybe sometimes in V3, it's more like a M. If you look at this shape, it's like a small kind of M pattern. If you draw a line, you could see. And if you come down to V5, V6 leads, it's more like a W pattern. It's not like fully evident. Sometimes you could see a notch in between this, in this U shape. You'll have a notch in between, which will appear like more like a W. So if you see a deep Q waves like in V1, V2 leads and the M pattern V5, V6, that's it's left bundle branch pattern. And if you're seeing M pattern V1, V2 and W pattern or this kind of deep Q waves in V5, V6, then it's a right bundle branch block pattern. Just for like here you can see it's nicely the M pattern here. Yeah, here's and there's a W pattern. If you see it, it's not like fully evident here anyway. Okay, so we're coming to the end of the main the pathology discussions about ECG. So we're just going to touch on electrolyte disturbances, which will be reflected on the ECG. You must have heard about hypokalemia and hyperkalemia. So it's interesting, like if you have a severe hypokalemia or hyperkalemia, you could pick up on the ECG phase. Anyone would like to say what is the normal range of potassium?
3 to 5 milliequivalents per liter, sir.
3.5. Yeah. 3 is still on the lower limit. 3.5, like, anything more than 3.5. But for keeping, the normal level is just roughly around, like, anything between 4, above 4 is fine. But it should be less than 5. So in this ECG, like you could see, like, the tall T wave. In hyperkalemia, you get tall T wave. It's called tall tented T wave. You could see it's more like a tent. Are you able to see this one? It's very tall. It's not normal. It's very abnormal. So in hyperkalemia, you get a tall tented T wave. The main problem is why we are worried about hyperkalemia is when the hyperkalemia like gets past the 6, the potassium level in the blood goes more than 6 and above, then you get more complications, especially in people with renal failure or like people having any other electrolyte problems. Then you are worried, like because hyperkalemia can cause cardiac arrest. Because sometimes the hyperkalemia goes more than 7.5, then they can cause cardiac arrest. So that's why we are worried about these kind of, when we get these ECG changes, the next thing we do is like take the patient to straight away to ICU, monitor, put them on a monitor, check the potassium level, start treating to reduce the potassium level. The equally, like if in hypokalemia, the next slide will be like this. Also, this is almost pre-cardiac arrest. This is very tall, almost taller than the QRS complex. This is your QRS complex. This is a T wave. You could see it's almost like a mountain. So this is very dangerous. Like this patient is going to have cardiac arrest sooner or later. So this is the main worry we are like why we look at this ECG in the background of hyperkalemia. See, it's almost getting like broader and broader. The more broader, then we are worried they're going into cardiac arrest soon. Hypokalemia is just opposite. It's difficult to see the T wave. Can you all see? Like it's hardly the T waves. There it was like big spike. Here you could hardly see the T wave here. Just opposite. That's hyperkalemia. That's also abnormal because hyperkalemia can also lead to cardiac complications as well. Here you could hardly see any T wave there. Here at least you can see, but the previous ECG it's difficult to see. Then in hypercalcemia, sometimes you can see a narrow QT interval. So in this, you could see the QRS complex is very narrow. Normally it's less than 0, normally it's like less than 0.11 or 110 milliseconds. Here it's hardly more than, maybe 1 small square or maybe 2 small square, like it's very pathognomic. Because hypercalcemia can cause cardiac arrest as well. So that's why we have to be very careful, especially in people having treatment for malignancy and all, like some of the malignancies cause hypercalcemia. Yeah. Anyone would like to come on this ECG? Come on, the boys are quiet. Are there many boys in this group? I could hardly hear boys. Come on, boys, show your strength. Anyone like to come on this ECG? Well, let's go to the other one. Okay. So if you look at this ECG, V1, it just looks, the ST segment looks isoelectric. Sorry, excuse me 1 second. Okay, if you look at this ECG, the V1, like the ST segment is isoelectric. If you trace this ECG, you could see the ST, the slight ST segment elevation. But if you look at this here, is some slight ST elevation. But this ST elevation, you could see it's slightly kind of convex here. Okay. Convex to the right. Same thing, if you see this ST segment elevation, V4, V5, V6, almost all leads has the ST segment elevation. If you look at V1, V2, you know, AVF, AVL not prominent. Are you guys able to follow the ECG?
Yes, sir.
Yeah, this happens in like acute pericarditis, where you could have a slight, this kind of saddle-shaped ST elevation in almost all leads. If you try to compare this ECG with the previous one, where you have an acute ST elevation in ECG, you had in only few leads, like V1 to V3 or V4, very rarely V5, V6, but you won't have it on all these leads. If you have an ST elevation in almost all leads, like this pattern, like, the kind of a saddle shape, then it's acute pericarditis. This ECG, like, obviously you'll have the diagnosis there, cardiac tamponade. When you have a pericardial effusion, there is fluid around your heart, like chambers. Obviously, the heart is not able to pump well or contract and expand well. So because the fluid is like pressing on it. So that's why when you record the ECG, because of the fluid around the heart chambers, you see the electrical activity that's the ECG case, you could see is very tiny. Normally these complexes are bigger. Here in pericardial effusion or tamponade, you see this is a very small one. Also in this one, if you carefully note this ECG, this QRS complex is different from this one. It's called electrical alternance, where there's one small complex followed by a slightly big complex, another small complex. Maybe it's much more easier on the next ECG. Yeah, it's called electrical alternance. This complex is different from this complex. This complex is, these two are same, but these two are same, but these two are different. It's called electrical alternance. When you feel a pulse for this patient having a pericardial effusion with cardiac tamponade, you feel one pulse is good volume, the next pulse you feel very feeble volume, and next pulse will be normal. Like alternate pulse will be like, this kind of pattern will be ongoing. Then it's not subnormal. Okay, are you guys ready for the quiz or you're bored? I think we are in by 15 minutes the session. There's few more, only there's about 10 or maybe less than that ECGs are there. Are you okay to carry on?
Yes, sir.
Yes, sir.
Okay. So this one, like, I'm going to like ask a question. Maybe you guys like take turns and you can answer. Okay. The first ECG, the question is here. What is the heart rate?
100, sir.
How much is it? Sorry, I didn't hear it. Sorry.
100, sir.
100. How did you say? You're nearly there.
3 big boxes.
Yeah, if you calculate like this one, it's almost on this big, the border of this big box. 1, 2, 3, 4. So how much should it be?
25, sir.
Sorry? Sorry, I didn't hear this. Sorry, your voice is very feeble. Say again.
75.
25, yeah, it's correct. Yeah, so it's good. Okay, this one. What rhythm is this? Normal, abnormal. If it's abnormal, what abnormality?
Normals.
Normal. Why do you say it's normal? I know it's difficult for you to just trace.
Sir, prolonged PR interval is there, sir.
Yeah, that's it.
Otherwise,
Now you got the diagnosis. What's your name? Sorry,
Praveen, sir.
Praveen. You got the diagnosis, Praveen. Yes, you could see the PA here, and that QRS complex here.
VA blocks.
There's a wide.
First degree.
First degree
AV
AV.
blocks.
Yeah, absolutely. Yeah, that's the first degree because it's a PR, prolonged PR interval in the ECG. This one. Anyone like to comment?
Sinus bradycardia.
Fantastic. What is the heart rate?
Less than 60.
Less than 60 years. Just tell me, like, roughly. Tell me together. Yeah, it's one big box, 2, 3, 4, 5, 6, 7, 8. almost 8.5. So let's take
40, around 40.
it's less than 40. I would say it's 35. Yeah. Okay. Good. It's almost because it's P wave there. We are going to say a sinus, but it's severe. Yeah. Okay. Severe sinus bradycardia. This patient needs, like the previous ECG, the patient needs admission and monitoring closely because they are more likely to have a cardiac arrest soon. Because severe bradycardia, unless they are on medication which causes bradycardia, we need to stop the medication and keep them under monitoring with ECG tracing or the cardiac monitor. Okay. This coming to the ECG, like to comment?
Atrial
Atrial flutters,
fibrillation.
sir.
Sorry?
Atrial fibrillations.
Atrial fibrillation. Why do you say
Flutters.
flutter? Not really.
Atrial tachycardia.
What's that? Sorry, the last one I couldn't hear it.
Tachycardia.
Yes, you're right. Yeah. You got the answer. Half of the answer is right. You get half point. What is the thing?
Sinus, sir.
Yeah, absolutely. Because you could see there's a P wave before each QRS complex. So only thing is the heart rate is like it's almost nearly 140 kind of thing, nearly the 130 to 140, but it's regular, so it's sinus tachy. See 130. Okay, anyone like to come on the ECG?
PSVT, sir.
Morbid.
I could hear somebody saying something about morbid or something.
3:1
Sorry,
block, sir.
sorry. Can you speak out a bit louder?
3:1 block.
Okay, let's do it together. Okay, you got a P wave here, followed by QRS complex, and there's a T wave. Okay, and there's a P wave again, followed by QRS complex. If you see the gap between this P wave and QRS complex is wider here, there's a T wave, and there's another P wave, and this gap is also wider than the previous one, and you could see the
Ventricular.
So after this one, the P wave is there, but you could not see a complex. What is this one? If the P wave, the RR interval or the PR interval gradually widens, and after that few beats, if there's a missing beat, what is it called?
Ventricular phenomenon.
Yeah, absolutely. Morbid type 1 or Ventriculax. This is probably the easiest of all the ECGs we have. Who would like to take this ECG? Diagnosis, or you want to just read the ECG?
Anterior wall MIs.
Anterior wall may good. Why do you say this?
V2, V3, V4 ST elevation, V1 ST depression.
Yeah.
Reciprocal.
Change it. Excellent. Yeah. Whenever you have an ST elevation in the one lead, just look at the opposite, diagonally opposite walls. Like if you have it in the anterior wall, look at the inferior wall. Likewise, if you have it in the inferior wall ST elevation, look at the anterior wall, what's happening to the ST segment. Because we discussed, we can get ST elevation various things like hyperkalemia. You can have in the pericarditis. There's various reasons why you get ST elevation. So we need to make sure it's the MI. So this is we already seen. I'm sure all of you will be able to answer this one.
Under branch blocks.
RBB. Right
Good.
bundle.
Good, good, excellent. This one is almost a repeat of the previous slide we discussed when we started this lecture. What is the diagnosis? Or answer the question: is this patient having a myocardial infarction?
Anterior septal wall. MS.
If you look at the inferior wall, there's a ST elevation is there, 3 AVF, and T wave is inverted, deep T wave inversion.
Deep TV.
Yeah, deep T wave inversion is there. So it's almost an evolved inferior wall MA. This one, normal, abnormal ECG phase, rhythm strip.
Ventricular fibrillation.
Ventricular.
Yes, absolutely. This should, whether you pick up anything else or not, you should be picking up this one. This is very important because you can't wait or delay. The moment you see this trace, you should be running for the defibrillator to give a shot to make sure it's safe to do it. Like everybody should be away from the bed, and the oxygen should be off before you give a defib, or else it can cause complications. This one,
Flutters. Atrial flutters.
Atrial flutter.
good. Yeah, that's it. How was the session? Hope you guys able to learn something new.
Thank you, sir.
Thank
you.
Okay. Just let me know. Like, would you like to have more session in ECG, or you want me to focus on other aspects of cardiology and general medicine topics, or
Sir, can you take murmur topics, sir? Murmur.
can do murmur. Next class we can have murmur. Okay. So we can discuss that. But ECG, like, are you comfortable in identifying the basic ones?
Yes, sir.
Yes, sir.
What I don't want you to miss is the acute MI. No, not like worried like you're going to miss the butter's branch block and all. But the important thing is like you have to pick up the ST elevation MI, ST depression, the NSTEMI, and the VF VT. The other thing is like the LBB. Why is it important? Is sometimes an acute MI can present as an LBB instead of the ST elevation. So that's one of the diagnostic markers of a new onset LBB that can be a marker of acute MI. Just keep it in mind. So whenever you answer the causes of MIS apart from the ST elevation, so you'll have the LBB comes as well. Okay, so we can discuss the next session on murmurs. But I like it to be more interactive. Like now, then only you guys will learn. So it's very it's very important that you use the technology. I think we don't have this technology way back when we were doing our MBBS. So you guys are lucky. So make use of these kind of lectures or whatever. The online sessions. Feel free. When you have this session, just feel free to ask questions. You don't need to feel that you should be asking questions only to your tutors or assistant professors. You can ask any of the alumni lectures as well. We'll be more than happy to answer your queries. Because what we want you guys to get out of this meetings is just improve your thinking and get all the expertise of all the the alumni, the doctors, because they all are different stages of their career. So it will be useful to make use of these opportunities. But feel free to ask questions. So the only problem is at your level, you always have this what do you call the restriction, or you don't want to ask questions. You always feel how the opposite. Okay. So we'll have the next class whenever the slot is free. I think FIDA is organizing the sessions. FIDA, are you there or you'll finish? FIDA, you there? Okay, any questions? If there are no questions, shall we close the session?
The chat box.
Oh,
Some
chat box.
questions are-
Let me see the chat box here. Sorry. So the first one, the question is ST elevation from Praveen Raj. ST
Sir, I
elevation on lead
asked
3.
I chatted during that time, sir, on 12 or 11.
Okay, have you got it cleared? Your questions are clear?
Yes, yes, sir, yes, sir.
Yeah, okay. So I think you asked a few, sorry, I missed.
Jayashree, please.
Because what I did was I just put my video camera on the side because of the screen sharing on the, I put on
No
the slide.
problems, no problems.
I didn't see those chat till now. There's a question from Nirain Moli, is it? Tall T wave. Yeah, because the T wave, like potassium plays important role in the cardiac conduction as well. So it's useful for the cellular transport. That's why you get a tall T wave, which is a sign of the ventricular repolarization. A lot of T wave, the potassium accumulates, intracellularly as well. Toss points. Okay,
Okay, sir.
that's a nice. Okay, it's very rare one as well as it's a very complicated one, where a patient will have a severe tachycardia starting small like a spin, where you see like one point and then like it's like more on R on T, in the QRS, the ECG. Like, let me just go back and show the normal ECG. Okay, so this is the R wave and T wave. Sometimes due to severe tachycardia, this T wave can fall on the R wave, or rather R wave can fall on the T wave. That will initiate a very severe tachycardia that's called torsades, and is usually unless you treat it, it can get into cardiac arrest. That can cause broad complex tachycardia. It's more like a spin. Once it started, the tachycardia cycle gets worse. It's more like a spring coil. Are you able to understand?
Sir, yes.
Yeah, it's called R on T phenomena. Then that stimulates this the torsades thing, where you see like more like a small coil, and then it gets more springs along the ECG trace. Then you know that it's very dangerous and it can cause cardiac arrest. That's the main worry we are about. And we have to give medicines like medicines, antiarrhythmetics, to slow down the cardiac conduction, or else this patient will end up having cardiac arrest. There are a lot of medicines which are used, like quinidine, the isopropyl. There's a lot of antiarrhythmetics which are used in the emergency settings for the controlling the torsades. But usually, it's very difficult to treat once you go to the torsades. Okay, any more questions?
Thank you, sir.
Okay, thank you very much. So we'll meet during the next session. Until the time, I hope you guys enjoy the rest of the teaching and the time. So have you guys had the formal face-to-face classes restarted, or still only on the online teachings?
Online classes.
Only online classes, is it? I think from
No.
16th onwards.
No, sir. November 16th, when
Okay, starting from 16th.
college will open, sir.
Okay. All right. Thank you very much. Good evening.
Thank you so much.
Thank
sir.
you so much, sir. Thank you, sir.
Thank you.